Good evening, all the students present here. Today, topic is infectious disease and tropical medicine. And the speaker that we have here is Dr. Anand Joshi, sir. He's a consultant, intensivist, and physician at Government Hospital, Hyderabad. So you can start. Thank you.
Thank you, Fatima, and welcome back. I think this is the sixth or seventh talk, a lecture on the series of the infectious disease. I will just try to get the settings done. So far, we've covered a majority of sexually transmitted diseases. We have covered HIV/AIDS. We have covered major tuberculosis. We have covered all the spectrum of antibiotics, general introductions. Now we are going to the specific diseases. I'll try to transition and club the diseases as much as possible. Hello? Hello? Yeah. I will try to transition it in a very gradual manner. Other diseases, the smaller diseases, it's practically impossible to cover all the infectious things, but important points will be covered. I've tried to squeeze as much in one session, but I don't want to overload it also. Otherwise, it doesn't make sense. So in today's one, I'm going to cover almost 6 diseases. As a continuation of the tuberculosis, let's look into another mycobacteria, which are very clinically important from the Indian perspective, and that's the leprosy, also called as Hansen's disease. So it's a chronic infectious disease caused by Mycobacterium leprae and transmitted mainly by the respiratory droplets. So it's a respiratory droplet transmission. There is a lot of evidence for its presence in soil and also the vector. So there is a little bit of debate among the epidemiologists that. Sorry, somebody's asking a question.
All the aspirants, it's going to be a very interactive session. You can also unmute your mic or you can also type it in the chat box. Thank you.
Yeah, if somebody types in the chat box, do you mind just letting me know so that what it's typed so that I can respond to that? Right. So coming back to the Mycobacterium leprae, so there is a lot of debate among the epidemiologists that it can get through the soil and vector, but that's again a debatable. It has a predominant inclination for this mycobacteria to affect the skin and the peripheral nerves, mucosa, testes, upper respiratory tract, and eyes. It has been found to be very much endemic in tropical countries, particularly Indian subcontinent that extends right from Pakistan till Myanmar, and Brazil, Indonesia, and Southeast regions. As other Mycobacterium tuberculosis, it's a very slow growing intracellular acid fast bacillus. Incubation period is really long. It can take from 2 years to 40 years with an average of 5 to 7 years. So when you got this infection, you will never trace it back. Its doubling time is almost 14 days in the mice, so it cannot be cultured. So it's not an easily grown thing. There is one important thing which has been mentioned, that the transmission requires a prolonged close contact. So if you have just passed through somebody who has sneezed out a Mycobacterium leprae, it is very unlikely that you might be getting it. Another important thing about the pathogenesis or pathophysiology is that host immune response will determine the disease spectrum, and I will tell you what a disease spectrum is. So those who's got a strong immune cell-mediated immunity, they will have a tuberculoid kind of leprosy, and those who has got weak median immunity will have a lepromatous leprosy. And the person depending upon the in between them will have a varied thing from tuberculous to lepromatous, which is classically called as TT as a tuberculoid, BT as a borderline tuberculoid. BB is absolute borderline. Then we have borderline leprosy, and then the lepromatous leprosy. And each of them will have its distinct feature, and the infectivity will vary for these people. Classically, these three things are differentiated based on the lesions or the symptoms, like the skin lesions, nerve lesion, where in a tuberculoid type we have only few sharply defined annular macules and plaques are seen with the central clearing. Again, as these skin lesions, which are much more demarcated, they become more and more lighter and less demarcated when it comes to the lepromatous side. When you do a biopsy, what you will see is there will be a more of a giant cells in the skin lesion for a tuberculoid, whereas you'll be able to see the acid-fast bacilli when in a lepromatous side. In terms of involvement of the nerve, skin lesions anesthetize early in tuberculosis. Near lesions sometimes enlarge, and the nerve abscess is most common in borderline tuberculosis. Remember, abscess is a protective mechanism for our body to contain the bacteria. However, this in lepromatous leprosy, where there is less of cell-mediated immunity involving, and it is more of the bacilli which is causing a problem, you have nerve palsies. They are much more eaten away, and there will be hypoesthesia, which will be a late sign. When you're trying to make a smear and do an acid fast, these acid fast bacilli are more likely to be seen in a lepromatous as compared to the tuberculoids. There will be a lot of lymphocytes in the tuberculoids, whereas there will be less in lepromatous. The surrounding cells of the macrophage differentiation will be classically seen as a tuberculoid one, whereas in lepromatous it will be less differentiated. So is for the Langerhans cells and the lepromin test. See, the lepromin test is, as you know, it is the immune reaction to the injected bacilli. So when you inject it in the tuberculoid type, where you have a strong cell-mediated immunity, obviously your lepromin skin test is going to be positive. However, when it's a weak cell-mediated immunity, as in lepromatous leprosy, you won't get it. The CD4, CD8 count again will be less more in the tuberculoid and less in the lepromatous leprosy.